Hi, my name is Jill Olmstead. I'm a gastroenterology nurse practitioner, and welcome to my MASLD Community Network podcast. So the podcast that I'll be introducing will be a serologic step-by-step presentation on how to work up patients with elevated liver enzymes. In my general gastroenterology practice at Providence Health in Southern California, this is a common patient complaint that I'll see present to my clinic. So elevated liver enzymes. So when you're reviewing your patient's records, one of the first things that you want to identify is this an acute phase or is this a chronic phase that you've seen? So patients that have elevated liver enzymes that's only been for a month, but less than 6 months, this is what you'd consider an acute disease process. If it's chronic, then it's going to be over 6 months. As you start to think about the different causes of elevated liver enzymes, you want to look at the different potential disease processes, which could be autoimmune hepatitis. It could be serologic evidence of primary biliary cirrhosis, could be Wilson's disease. But you also want to look at potential infections or drug exposures, and also keep in mind if your patients are pregnant as well, if this is related to your pregnancy. So as you go through that step-by-step approach, you're looking at whether there's hepatocellular injury, which means your AST and your ALT markers are going to be elevated, or is there also cholestatic injury? So then you're looking at your total bilirubin. Is there damage that's being done to your common bile duct? So as you go through this thought process, you're going to be putting together a plan on what blood work that you're going to be ordering for your patients. Also, you're going to be doing that initial assessment. Once that patient is sitting in front of you, are they jaundiced? Are they itching? Do you see ictal sclerosis in their eyes? Is their abdomen distended? Do they have a history of alcohol use? Because this is also the number one reason for elevated liver enzymes. And MASLD, or metabolic-associated steatotic liver disease, is also the second leading cause of liver transplantation. So that's something that we have to keep in mind when we're also examining our patient. We have to check their BMI and also see if they have any other comorbid conditions. Are they diabetic? Could potentially this be related to, a metabolic disorder? Do they have high cholesterol? This is also going to add into that picture of a metabolic active liver disease. So as you're looking at your patient, you're looking at that liver markers. And depending on when the last time the liver enzymes have been elevated, you're probably going to want to repeat those within that certain time frame. And remember, one of the indicators for increase in alcohol use, you're going to have a ratio of your AST to ALT. You're going to have a 2-to-1. And also your GGT will also be elevated. So keep in mind of that. Be mindful though, as far as being biased to your patients and assuming that they have alcohol use. This is something that happened many years ago. And we want patients to be open with us and honest and giving that good history. So part of that initial history, you're going to ask them, what are their current medications that they're taking? What is their history of alcohol use? And what's important that I find even in my own practice is I'll ask them, what is your history of alcohol use now? But what was it like a year ago? Because by the time patients see you in your clinic, their primary care doctor could have already ordered liver enzymes and they were elevated. And this was 3 months ago, and your patients could have stopped drinking at that time. So it's not uncommon when you ask them, what is your alcohol use? And they say nothing. I don't drink anything. But 3 months, 6 months prior to that, they may have been drinking 4 beers in the evening. So it's important to get that past history from your patients to be able to make a good assessment on how you're going to risk reduce their hepatic injury and what type of guidance that you're going to give to them. So part of that serologic workup, you want to look at your patient, look at their age, see what potentially their risks are. And so you want to make sure you're checking your viral hepatitis. You're going to look at your hepatitis B. You want to get a surface antigen. You want to get a surface antibody to see if they've developed immunity. Look at your hepatitis C. And when you start looking at your autoimmune markers, you want to order an ANA. You want to order your anti-smooth muscle antibody, your anti-mitochondrial antibody, to make sure you're also ruling out other different disease processes. What's very rare, but we do find it in our practice, is Wilson's disease and alpha-1 antitrypsin deficiency. So these are markers that you also want to evaluate based on that patient's history and based on how complete of that history may be. So that's a marker that you're going to look into is a ceruloplasmin and alpha-1 antitrypsin antibody. So a lot of times I'll see patients that may have chronic elevated liver enzymes, and it may have been a year or two since they came back to reevaluate to see a clinician. So you want to go back and look at that history to see if those other markers have been ordered for your patient to make sure we're not missing, or the clinician or the gastroenterologist previous to seeing you had not missed it as well. You want to look at iron studies. If there's iron overload, then potentially your patient could have a genetic disorder called hemochromatosis. So actually, ferritin level will be part of that marker that you'll be looking at. And also, don't forget about celiac disease. Celiac disease can present with elevated liver enzymes. So you want to be able to say that you've had a complete history and making sure that you're checking that as well. So once you do the serologic workup, then look at these markers, take that information in to really provide your patients with guidance. What you're going to find in your practice is the majority of the times it will be related to excessive alcohol use and MASLD, so metabolic associated liver disease. And this is because of our increasing episodes of obesity. And these are patients that have had weight, they've carried this weight on them for several years, and can be a chronic condition. And because of not being able to lose the weight, or because of other metabolic disorders, why it's difficult to lose weight, then that's why these patients can fall into this chronicity of this stage. So it's important to be supportive and to be able to provide as much guidance and support for them. Part of the workup I don't want to leave off is an abdominal ultrasound. Now, that abdominal ultrasound is going to show you, number one, if there's steatotic hepatitis, if there's a fatty liver presentation. But even more importantly, it's going to quantify your common bile duct. So it's going to look to see if there are gallstones or if there's a cholestatic behind this elevated liver enzymes. Now, you may already pick up on that from your patients if they come in and they have right upper quadrant abdominal pain. So that right upper quadrant abdominal pain is going to be a cue to you that they could potentially have gallstones, or there could be a stone that's stuck in the common bile duct. So you want to pay closely attention to that common bile duct size to make sure that there's no stone or stones that could be in that duct. And then also, what else can happen is that patients can even have sludge in that common bile duct. I think what's a common misconception with patients is that they feel that once they've had their gallbladder removed, and they're free of having to worry about ever having gallstones again. But I explain to my patients, you actually, even with your gallbladder removed, you can have stones or sludge that can develop, that comes down from the liver and develop in the common bile duct. So that's why it's important to be able to get that imaging test. Even more so important than your CT scan imaging. The abdominal ultrasound is very accurate at looking for gallstones or common bile duct dilation. And then if there is dilation, then you want to order an MRCP, which will actually be able to look in that area to identify if there's stones or sludge in that area. And then recommendations from that point would be ERCP, which is an endoscopic retrograde cholangiopancreatography. They actually can pull those stones out. Again, your history of presentation of your patient is key. So if your patient comes in the office with jaundice, then you know you're going to look at worrisome that the patient is an acute phase and they have extremely elevated liver enzymes. If your patient has abdominal pain, right upper quadrant abdominal pain, severe, they have a fever, then this is an emergency. This type of patient you may want to refer to the emergency room for evaluation. They could have, acute cholecystitis. Again, the majority of time of the patients that we'll see will be patients who have chronic elevated liver enzymes, which is related to MASLD. And it's really important that we're making that accurate diagnosis. Another test that I want to recommend is ordering a liver fibrosis score. Now, this is a test that is done serologically, but also don't forget about the FIB4 score. FIB4 score is a test that can be done actually even in your electronic medical record in the EMR. And this will calculate the percentage of fibrosis. And in our institution, if our FIB4 score is 2.0 or greater, then what we're doing is recommending a FibroScan to be able to differentiate between how much fat is in the liver and how much fibrosis, because that's also going to make a determination on what recommendations for therapies that you're going to be recommending for that patient. So to recap, I think it's important to have a systematic approach, but also your patient is going to determine how you start to work that patient up and how sick that they may be. You want to make sure that you're identifying a potential aggravating factor if it is related to a drug, and remove that, and then watch the continue to monitor the elevated liver enzymes and make sure that those start to reduce. You want to identify if there's some type of biliary obstruction or if there's an autoimmune disorder, and then you're going to make your recommendations based on that. And if if you identify if there's excessive alcohol use, you want to make sure your patient is abstaining from alcohol, and making referrals potentially to a hepatology center in case your patient is so ill that they do have to be considered for a liver transplantation. So usually advanced practice provider can manage these patients in the clinic, unless they are in fulminant liver failure, then they actually need to be transferred to a tertiary center. But liver health is going to be important for advanced practice providers to provide the guidance for the patients. So I thank you for this time, and I encourage you to visit the MASLD and MASH Community Network sites. You can visit my site, or we have other amazing colleagues that have also had some recordings to provide you with some also additional information. So thank you.